I'm a physiotherapist at Vancouver Acute, and I've been asked to talk to you about a patient of ours that went home in the Home First program. She was a woman who was in hospital for about 3 months. She'd been through the mill. She was on hemodialysis 3 times a week. She'd had a stroke while she was in hospital. She had a long ICU admission and had a tracheostomy for much of her time, and she had a PEG feeding tube because she was unable to swallow. The family had decided at this point that she would have to go to a nursing home because they just couldn't manage her care needs. And when the Home First initiative started, we went back to the family to ask if they would consider having her home and that we would put in some extra care. They were very reluctant to do so, but decided that they would give it a try and that we would have a home visit. At this point, she could walk with 1 or 2 people helping her. She needed a mechanical lift in and out of bed about half the time, depending on how she was feeling. So she was quite immobile. Anyhow, we decided to do this home visit, and it was quite a complicated communication process because she spoke no English. She was extremely deaf. Her husband spoke no English, and her son, who spoke English very well, spoke no Cantonese, and so he asked that we always have an interpreter around to communicate to the family rather than him doing the interpreting for us. So we understood that there were stairs going into the house from the outside, and the occupational therapist and I decided, well, we would just bump her up the stairs, and if she was successful in her home, then we would build a ramp so she could exit her house. When we got there, the stairs were in fact inside the house, and they were really narrow and really steep, and there was no way we could put a ramp in. And so at this point it was, well, do we just turn around and just say this is impossible? We decided then to try and get her to get up the stairs. And remember, she was a woman who was still being lifted out of bed. And it was amazing. She was so motivated that she actually climbed these stairs with our help and managed really well inside her home. She still needed 1 person with her at all times, and the family decided that they would try and have her home. The good part was having the community OT there because he really understood the resources, and he was able to explain to the family what would be available to them. They were able to have a home support worker who spoke just Cantonese, and we requested that they have the same group of home support workers because she was so immobile that if you didn't know her well, it would be very hard to get her up and get her going. Thinking about why this was successful, I think it's because we chose the right patient. I think we targeted the person who had high physical needs, but who was cognitively intact and who was motivated to be home and who had a very supportive family, and I think that's the key issue. I think these patients have to live within a family unit because if they're immobile and if they have any cognitive issues at all, they can't be left alone and they would need 24-hour care. So living in a home environment with somebody else usually makes for a successful discharge if we can put in the support services we need.